speaking in English. And I'm really, really honored to introduce you Dr. Demetre Daskalakis from the Deputy Commissioner at the New York City Department of Health. He was also the head of the HIV clinics in Mount Sinai, New York. And he's mainly a queer health warrior. He's really into helping the gay community in New York, and I'm really, really honored to introduce him. He will talk about harm reduction and crystal meth in New York, and I think you will like it. So, Demetre.
Thank you all for having me. I need to make sure I get pictures of this so people won't believe that such a large audience is coming to hear about drugs and harm reduction in Tel Aviv. So I want to thank Roy for inviting me and for all the sponsors, but I want to first of all thank all of you for being here. So let's start with that. Thank you so much. We're almost, there we go. Thank you. So today I'm going to tell you the story of what's happening in New York City around crystal methamphetamine and also other drugs. And also, I was saying to folks who I was meeting when I was walking in, our story is also a story in progress. We don't have a final answer. Everything is evolving as drug use evolves and our population evolves. So I'm going to really start off by talking a little bit about crystal meth as background. Just really what methamphetamine is, and also why I'm worried about it as someone who works theoretically in infectious diseases and disease control. So rather than coming from a space of working in drug-related public health, I come from the perspective of working in HIV, STI, and other infections, and I'll tell you why I'm talking about this rather than other people who are doing public health around drugs. I'm going to then tell you what we learned about crystal methamphetamines in New York City, and when we went on a voyage to see what services we had in New York City to address the needs that we were hearing from our population. And then I'm going to present to you our program that we designed based on our evaluation. And really, it's going to be, I'm not going to keep it technical. I'm going to really just talk about what our experience has been like and what we're seeing so far. But I'll present Recharge, which is New York City's first municipal program that is designed to help people who are living with methamphetamine use and abuse. So first, background. Very simply, what is methamphetamine? What is meth? I think that it sounds as if there's been plenty of media here in Tel Aviv and in Israel, so you're very well aware. It is a man-made stimulant, so it's something that can be produced from very common supplies that you can purchase at pharmacies or drugstores or other places. It's highly addictive, and it affects the central nervous system. But the reason that it lands on me rather than on people who focus on other drugs, is that it's associated with increased likelihood to engage in sexual risk-taking behavior for HIV or STI. So in general, I never like to use the word risk-taking behavior, because risk-taking behavior is often fun. Sex is fun, pleasure is important, and so it's really not about condemning pleasure, but about planning ways that pleasure can be safer. I think, as you heard from Roy, the idea of really harm reduction strategies to maintain a sexual life that may or may not include drugs, but that is healthier if you are including drugs than it would be if you didn't have certain education and support. And also, people who use meth, at least in New York City and other parts of the country, appear to be at increased risk for HIV infection. So I'm going to just give you the details. These are data slides. They look a little boring, but there's just one very common thing, that certain drugs we know are associated with increased risk of HIV seroconversion. We also know that different people use the drug. So at least in the US, what we find is meth, at least initially, used to be more common among people who were living with HIV. Poppers were more common among people living with HIV, and then also erectile dysfunction drugs were used fairly frequently. But when you look at many of the studies around crystal meth, it tends to be one of the strongest drugs, at least in the United States, associated with HIV transmission or acquisition. So why am I telling you this? Well, when you tell people who are doing work in drug abuse in New York City that you want to do work in methamphetamine, they look at you and they say, why? No one dies of methamphetamines. We worry about opioids. We are worried about heroin. We're worried about pills. We're not very worried about methamphetamines. And so when our community said that we had to do something about methamphetamine, rather than saying we don't have a home for it, we took it into the infectious disease part of our work. So though it has very little to do with infectious disease every day, it's why I'm here talking about it rather than someone who theoretically is a drug expert. So the reason that methamphetamine is involved with HIV transmission isn't just because of methamphetamine. It just facilitates either characteristics of behavior or the individual and events that may potentially lead to transmission. Now, I'm going to step back and say something really controversial, which is that in a universe of PrEP, pre-exposure prophylaxis, and a universe that undetectable is equal to untransmittable, meaning that people who are treating their HIV and who take their meds every day don't transmit HIV, the role of drugs may eventually become less important in infectious diseases, given that we have better strategies for preventing HIV, regardless of drug use. And so that's an important message. But at least historically, methamphetamine facilitates potentially more condomless sex. So this slide is old. We still call it unprotected here. We don't call it unprotected anymore. We call it condomless. And also, it could facilitate other characteristics of the individual, like methamphetamines may increase STI acquisition. Also, remember that sex can be more fun / also aggressive with methamphetamines, which can lead to more trauma and potentially more risk for HIV acquisition. So the story of this slide is just to say meth is one of the cofactors that could come together to create a storm where potentially HIV transmission could be facilitated. So there are some studies that show that meth is definitely associated with increased risk-taking behavior, and this is one that I like that was published from San Diego in 2016. So really what they did is they looked at men who were coming to get tested for HIV at their very, very good testing program. They have one of the best testing programs in the country. They test for acute HIV infection, they do viral loads. It's really, really, really intense testing. But what they did is they asked people about methamphetamine use, whether they were taking it, whether they just started, whether they've never taken it, and they scored them for using a risk measure to see how high their risk was for either HIV or STI acquisition. And so what they saw was they compared people between first visit and second visit. So these are people who, for the first time when they came to get tested, said, I've never done methamphetamine. If they did do methamphetamine, if they started in between visits, their risk factors went way up. So by being on meth, their risk for HIV using that measure increased. Individuals who, when they first came, said, I do meth, they had a high risk for HIV, but if they stopped it, their risk went down. When you have individuals who always use meth, so on the first visit and subsequent visits, they had about an even risk, so it was consistently high risk. And individuals who never used methamphetamine, men who have sex with men, had still risk, but lower than their counterparts on meth. So really, rather than saying, look at HIV seroconversion or people who get HIV, this was a look to see really from the risk behavior perspective if meth was associated with higher risk taking. And so one of the other findings in this very, very small slide, and it's small on purpose because I don't want you to read it, is that it's not just methamphetamine. People do a lot of drugs in the context of having fun. Whether it's for partying, whether it's for sex, the list is pretty endless. So up here you'll see GHB, ecstasy, marijuana, cocaine, heroin, crack, ketamine. And I can tell you, without looking at this slide, I take care of patients. I see people living with HIV and folks who are taking PrEP. I can tell you that I think in the last few years, I've seen a lot more individuals who are really titrating drugs, who are using drugs to really optimize their sex lives and to optimize what's going on in their party world. So I think that it's really important, rather to shun away from it, to say it's not just methamphetamine. We have a little bit of a bad reputation for methamphetamines, but we need to think about the other drugs, which is something that we learned as we went along our voyage about really reintroducing methamphetamine programming back in New York. So in another study, they actually looked to see, they used fancy statistics to say, regardless of other things that people are doing, how much of the risk for HIV infection, for transmission and infection, was caused just by stimulant use. That's cocaine primarily and methamphetamine. And in these two studies, you can see that there's a high amount of attributable risk. So that's almost 30% of the attributable risk, over 30% of the risk was attributed to the fact that someone was taking a stimulant. So meth is a real potential risk for HIV and STI. But there's another thing that's important. Don't look at this slide, I'm just going to tell you. So the other thing that's really important is that we really need to be careful about categorizing folks who are using meth as people who are unable to either use PrEP or take their HIV meds. So the data is really mixed. So when you look in some studies, people who are taking methamphetamines are often very aware of their risk. They're often more likely to use pre-exposure prophylaxis. And if they're HIV positive, the data is a little bit mixed about whether or not their adherence to their ability to take the medicine every day is good or bad. But I will show you some of the data that says that potentially some people may be at risk of losing the control of their virus load because of their methamphetamine use. So this is a study, and I'll walk you through it really quickly. It's pretty straightforward. They looked at people who were using methamphetamine, and they said, do they have a positive test in their urine for methamphetamine or a negative test for urine for methamphetamine? And so what they found was that first, individuals who said they never used methamphetamine and didn't have methamphetamine in their urine really showed that they had lower viral load. So this is a lower viral load, that's a higher viral load. So for those of you who know, viral load is the amount of virus in your blood if you have HIV. If you take your medicines, the viral load goes down. So what you'll see is never taking meth individuals who were on medicines were great. People who said they took meth but weren't taking meth actively at the time of their test, they also had very low viral loads. But if someone had meth in their urine, if they were actually taking methamphetamine, they tended to have viral loads that were higher, really implying that methamphetamine could potentially increase risk of not being able to take PrEP to prevent HIV or HIV meds to keep people's viral loads undetectable, U equals U, and preventing HIV transmission. Does that make sense? Lots of nodding heads. So it just means that some people who use meth may actually impact their ability to stay on medicines that keep them healthy. Now, people have done a lot of work in behavioral therapies for methamphetamine, like trying to figure out what we can do, like counseling or other support. So I just list here a couple of programs that were studied in the US and really mixed results. And so one of the things that we were very interested in when we were approaching methamphetamine and strategies to deal with folks who were using it was, could we push the envelope and look at medication-assisted therapy for methamphetamine? So who's heard of methadone? Methadone for people who use heroin. So it's taking a pill that replaces heroin so you don't use heroin. That's the idea. That's real harm reduction, where you're using one medicine to replace another. So we don't really have anything like that for stimulants. There's nothing like that for cocaine. There's nothing like that for methamphetamine. And so part of what we looked at as we started to create a program in New York was there enough data to really push our program into providing therapies that could potentially replace methamphetamine? And what we found was there wasn't a lot of data, but we were able to look at the data to inspire some of our work. And so I'll share soon that in our program Recharge, we are actually offering people medication-assisted therapy for methamphetamine if they decide they want to be abstinent from methamphetamine. So that's going to be really important. So we give them antidepressants that are a little stimulating, so it gives them a little bit more energy. And in some cases, we're actually giving them prescription amphetamines to replace their daily use of methamphetamine. And so I'm not able to tell you what the results of that are yet, but I can give you a preview that we're very enthusiastic that we've seen that it's actually working in the real world with our patients. So you'll have to watch for that in the future. It's too soon to say. So that's sort of methamphetamine as a background. So we know what it is. We know that it's associated with increased sexual risk-taking and potentially HIV acquisition, transmission, and STIs. But what about crystal methamphetamines in New York City? So this is from a survey that happens in New York every 3 to 4 years among men who have sex with men. And what we found was in the early 2000s in New York, about 14% of men who have sex with men, gay and other bisexual men, actually told us that they were using crystal methamphetamine. So that's a pretty significant percentage. And for those of you who are old enough, and by the look of the room, many of you may not be, but good for you. The people who were old enough to remember going to New York in that era, there was a lot of press, a lot of work around meth because it was a pretty significant problem. Then, the next time this survey was done, the numbers decreased to only about 4% or 6% who said they were doing methamphetamine. And in 2011, it went down to 4%. And so, what does public health do when public health has success? They dismantle their programs that are successful. That's just, it's welcome to tuberculosis, to HIV, to STIs. That's consistent across the board, not just the US, every country, that's how you save money. You say, okay, well, it's good now, it's over, so we're going to step away. And so the methamphetamine programs started to disappear, and then in 2014, we were up to 10% again, and that stayed the same in 2017. So we are not quite to our lofty heights of 2004, but we're seeing an increase in methamphetamine. Now, I don't have this in the slides, but one really important part of the story was that in 2014, our community activists from ACT UP, which I think you all have ACT UP too, so from ACT UP came to us and said, what are you going to do about this? There's an increase in methamphetamine, and what are you going to do? And so some of the pre-work that we did was inspired by the fact that the community said for us to pursue this. And really, we learned a lot more about what methamphetamine use was like in New York. And here's one of the interesting things that we found. So on this graph, it's the same survey, 2004, 2008, 2011, 2014, 2017. The blue bars are white New Yorkers. The red bars are black New Yorkers. And the sort of gray bars are Latino New Yorkers. So what we found was that the story of methamphetamine in New York completely changed. So it used to be older white men who were using methamphetamines, at least in the early days of the methamphetamine experience in New York. But what we found in this new resurgence of methamphetamine is that it's younger, it's more likely HIV negative, and more likely black and Latino. So why is that important? Well, it's important for lots of reasons. Whenever there's a racial disparity, it means that we're doing something wrong about reaching that community. But the second thing is that young black and Latino MSM represent over 80% of our new diagnoses of HIV in New York City. And so when we have this perfect combination of a drug that increases HIV risk in a community that is already at risk just because of the fact that they're in a social environment that increases their risk, we have an emergency that we have to pursue, and our community said, it's not time to wait, let's move it. And so then other important data comes out as well, the most recent one I don't have a graph of, so I only am showing you this, but this is showing you unintentional drug deaths in New York City, and what percentage of them actually involve methamphetamines. That number continues to go up. Now, why is that important? So I thought this was going to be enough to get people's attention in the public health drug world. The reason this is happening in New York is not because methamphetamine itself is going to kill you. It's that people who take methamphetamines mix with other drugs. And then we also have another problem in New York, and I'm not sure if you all have it, is that our cocaine, methamphetamines, it's being cut with fentanyl. I'm not sure if you have that. Do you guys have that? Good. Yeah. So fentanyl is a highly potent opioid, and they say it's cheap, and so they'll cut it with other drugs, and so people are thinking they're getting pure meth, and what they're getting is meth and fentanyl. And then if you've never taken an opioid before, that dose of fentanyl puts you over the edge. And people can go to the emergency room and sometimes die. And so this wasn't enough to get the attention of the folks that do drug-related work in public health. So it required, again, us to sort of focus on the HIV STD risk, but nevertheless, this is real, and so far the number's not changing. We continue to see a lot of methamphetamine involving deaths in New York City, although it is not the drug that is likely causing the death. So our numbers said that we had to do something. The data said that we were seeing methamphetamine in a population that was at really high risk for HIV and STI for other reasons. And we had our community activists saying, why are you sitting on your hands? Figure out what's next. Move faster and make a plan to address this problem. And so we did this by starting to do an internal investigation in New York City of what methamphetamine harm reduction programs look like. So since the mid-2000s, when methamphetamine numbers started to decrease, we had heard that the number of programs that were doing this work were decreasing. And so what we did was actually do a needs assessment to see what was available and what we had to make to fill the gaps of what was available. And so the first thing that we did was we found agencies that theoretically should know how to take care of people who were using methamphetamine. So we only found about 22. We then interviewed them, about 20 of them that were actually willing to be interviewed, and we asked them about whether they had specific crystal meth knowledge, if they had specific knowledge in working with men who have sex with men, and also what their strategy was. Is their strategy to get people to stop using meth, or is their strategy to do harm reduction, which could potentially lead to stopping, but doesn't necessarily need to. And then finally, we had to see if they actually had specific expertise in meth users, and if they had not only expertise in men who have sex with men or gay and bisexual men, but also if their programming focused on those men as well. They had a limited range of treatment approaches. I'll talk about that. And we also heard that there were actually waiting lists. So I'll just show you of the programs that actually met criteria. They actually weren't expert. They had some expertise, but they didn't focus just on methamphetamine. So it was in the context of other drugs. And one of the things that we heard from the community and have seen from our data is that this community is a lot different than other drug users. The opioid user and the methamphetamine user is not the same person. And so it's hard to clump them together in one program. Some of them had groups, about 3 of the 8 had groups that focus on MSM. Others were primarily MSM groups. The majority, 5 of them, were abstinence only. So if you were going to go in the program, you had to say, I'm going to quit taking methamphetamine and that's why I'm here. If you were interested in using it more safely or preventing some of the side effects or complications, you couldn't be in the program. Only 2 of them were pure harm reduction and 1 combined harm reduction and abstinence. And then finally, 3 of them had a wait list. Guess which 3 they were? They were the same 3 that were the ones that had complete methamphetamine focus. So the programs that really knew what to do, it was impossible to get into them. Others had immediate access, but their knowledge base, the work that they did, was different than being really purely focused on crystal meth. And so when we looked at New York and saw this problem, a couple of things became clear. We had to come up with a strategy. I'm not going to show you that. That's not important. We had to come up with a strategy that addressed the fact that there were limited areas, limited treatment options and strategies available. We had to deal with the option that people had to wait on a waiting list to get crystal methamphetamine specific services. We also needed to make sure that the services that were built in were focused very much on the community at risk for methamphetamine use and its complications. So not just having gay and bisexual men's health on the side, but having it be central to the work that happened. We also thought, though not something that we asked specifically, that building a program that combined behavioral, sort of mental health related services along with medical services that don't just only focus on drugs, but also focus on HIV and STI treatment and prevention would be a novel way to do this, a new way of looking at it, and really embed methamphetamine and other important primary care that people need to keep themselves healthy. And so that really led us to coming up with a program that we're going to talk about that is still pretty new. So I'm showing you some very preliminary information and data from the work that we've done so far. Now, the reason we're able to do it is that in 2014, the governor of New York State said that New York would be the first city in the United States, the first state in the United States that would end the epidemic of HIV by 2020. And by ending the epidemic of HIV, what they meant was that we would have fewer people newly diagnosed with HIV entering the system. So over time, our numbers of people living with HIV would go down. So one of the really important things that happened in designing this plan was that methamphetamines were specifically mentioned as part of the plan. And so when our mayor in New York said, we're going to invest $27 million in ending the epidemic in New York, and looked at me and my colleagues and said, how should we spend it? One of the things that we were able to point to was that this plan mentioned methamphetamine, so we were able to get specific funding, specific money that was designed to improve methamphetamine services in New York City, which is not something that you get on your lap every day. So it was exciting. But what we did was really look to see what our strategy should be in the context of this ending the epidemic plan. So we wanted to reduce new HIV infections among methamphetamine users. We wanted to improve HIV treatment outcomes among those using meth, so improve their viral load and their ability to take their meds every day. And also not just focus on meth and not just focusing on HIV, but really looking at methamphetamine as something that is in primary care, that addresses the fact that people's lives are complex, that they have complex social, physical, and mental health needs. Then also to figure out what we can do to help people either manage or reduce their crystal meth use. So one of the very clear things that we learned, and I think I've already said to you, is that we can't really create a program that's abstinence-based or one that's just harm reduction. What we were seeing was that there was a need for both. So we wanted to make an initial program that actually did both. Allowed you to come into the program for harm reduction, or allowed you to enter the program with the goal of quitting methamphetamine. And then ultimately, we wanted to focus on reducing some of the negative outcomes that people see with methamphetamine use. And we didn't talk about this yet, but hepatitis C is one of the infections that we see transmitted, sometimes related to meth use. So we wanted to see if we could create harm reduction strategies for people in the program to prevent these outcomes. Now, we started not from scratch. So one of the things that really helps us is in the US, we have a program called Ryan White. And Ryan White is a program that helps people living with HIV access services that aren't paid for by other insurance. So one of the things that tends not to be very well paid for is mental health and substance abuse, which is silly, but it's true. And so we actually built this program that I'm going to talk to you about around the Ryan White program. So something already existed for people who were living with HIV, but we actually didn't have a similar program for people who were HIV negative, but who were using methamphetamine. So what we did is we used our Ryan White money along with our ending the epidemic money from the mayor, and decided that the way that we were going to bring them together is by giving money to a clinical site, so someone who could prescribe medicines, could do HIV care, and could do pre-exposure prophylaxis, PrEP, as well as primary care, but that we would also include a community-based organization that didn't really do medical care, but had outreach to the community that was deeper and better, and would provide them what in effect would be drop-in centers that functioned as chill-out rooms whenever they needed them. And so really the idea being that we created these services that gave people what they needed on the street, but then also connected them very closely to medical services that would allow them to both access medicine for HIV and HIV prevention, and potentially behavioral services, mental health services, and medication therapy for methamphetamine use. So it was really trying to create what everyone in the US wants to do for opioid use, a one-stop shop, where when you land, you get everything. Primary care, drug counseling, drug, medicines, whatever you need, all in one place. And so what we came up with is something that we call Recharge. So that is our program in New York City that is about a year and a half old, working to address methamphetamine use. So it started with 0 clients. So I'll start with that. A year and a half ago, there was no one involved in this. It started from scratch, brand new, and we're really seeing some exciting data from them. So the model is pretty straightforward. It starts off with the idea of there being drop-in spaces or drop-in groups where people can just stop by. It's completely low threshold. There's nothing you have to do. You go to this community-based organization, it's Gay Men's Health Crisis, GMHC is the organization that does it, and it's just where you go to chill out. You could be high, you could be using, you just go there and relax, but in that environment, it allows you to contact people who are expert in methamphetamine use, and will provide you some services. So we're working now to add drop-in sexually transmitted infection testing services. So people can just come and chill out, and if they want to give a urine sample or a swab to test for gonorrhea or chlamydia, syphilis, and HIV, they can do it while they wait, but there's no pressure. But the idea is that it creates a community of individuals who can come and talk, and then ultimately, if people are interested in going deeper into what the service is, they're able to come and get either the medical or behavioral services that we have. And so once we have encountered people in these drop-in areas, we offer them access to primary care. And so our second organization is Housing Works. It's another organization in New York City. So these two organizations work together, and they move people from just the drop-in center where they can come as much as they want to, if they desire it, going to get a primary care doctor that also allows them to come in an open schedule fashion. So it's not like you have to have an appointment. You can drop in when you want. And so we made it very easy for people to come in. And those primary care doctors don't just focus on HIV. They do general primary care, but they also focus on prevention and ultimately referral to a mental health specialist who is, I think, on the vanguard of using medications to help replace methamphetamine use for individuals who elect to do it. So this is kind of a flow chart of how it all works. So we do a lot of work in social media to get the word out to people. We do lots of in-person and non-traditional outreach. So we go to sex clubs, we're on Scruff, we're on Grindr, we go to sex parties, everywhere to get the word out about the program. I'll show you some of the swag that we send as well. As well as going in the street, we also have our centers where people can walk anytime to have an intake, so to meet people who will let them know what the program is like and if they qualify. Then if they desire to come in, they get intake, they get linked to the programs, a lot of health education, and they really go into a couple of different areas. They enter through the medical area, and that includes all of the stuff that MSM should have. So they get evaluated for STIs, for HIV, whether they need vaccines, whether they need pre-exposure prophylaxis, if they need a psychiatric referral. They all have a psychiatric visit if they elect to do that. And again, part of that is the option of starting medicines to replace methamphetamine if people are willing to or interested in stopping. Additionally, there's a lot of other work that's happening around counseling and intake, motivational interviewing, really things that are trying to keep people connected to the primary care, to the medical care that then is linked so closely to the other social needs and the methamphetamine strategies that we've come up with. So this is very limited in terms of the data I can show you so far because the program is very young, but we've had about 90 drop-in groups, many non-traditional site visits, including bathhouses, sex parties, and we also go to house balls and kiki parties. I'm not sure if you all have those, but if you've seen Pose, I think you probably you know what I'm talking about. Paris is Burning. Maybe that works. Yeah, so we go to all those and we get lots of young kids and it's really exciting. And then health fairs and other neighborhood events. We also have swag, things that we give out on the street, and I'm going to tell you which one I told them to give out. So they give out a keychain and they go, no one cares about a keychain. That's nice though. And they said, we'll get socks out, and I go, they're not tall enough for the sex club. That's fine. And so I said, make a jock strap. And so the jock strap is a blockbuster, and everybody wants to recharge jock strap. And so we keep making more interesting merchandise to get out to people to remind them about the work. So we've seen a lot of clients that come, the numbers are actually out of date because we haven't gotten updated from them yet. We've had a lot of people who've come for initial medical visits. We've started a few people on post-exposure prophylaxis. One of the things that's been really interesting is that for the organization that runs the clinic, the Recharge program has been the #1 referral source for patients starting PrEP. So that's great. So the fact that we find people and we bring them in because they're interested in talking about methamphetamines, and at the end of the visit we have them start on PrEP is exactly our dream. And so it's a really great strategy. And the other piece of the news is that, again, this is not up-to-date data, but we've actually had people who've been evaluated for pharmacotherapy, and we're seeing more and more people in the program who are starting to actually agree to go on medicines for replacement therapy for amphetamine. And so, like I said, we're seeing really hopeful findings, and we expect to see more as the program matures. A lot of people taking us take us up on supportive services. So individual counseling is popular, group counseling a little bit less popular, but really everyone is interested in getting linked to some services if they come to us. So reminding you that about a year ago it had 0 people. We now have about 200 people who are enrolled in Recharge who actually completed their assessment. It's almost half and half, mainly HIV positive, 74 were HIV negative at the time that we did this. And so a lot of what I'm going to share with you now about who we're seeing comes from our data that's sent to us by the programs that we fund. And so again, it's only preliminary, but we'll definitely tell you a bit of the story of who meth users are in New York who are coming for harm reduction services with us. So the majority of our clients are male, as expected, because our outreach is very much focused on gay and bisexual men. Many are young, under 40. The majority are gay or bisexual. The majority are Black or Latino. Most of them are born in the United States, have a pretty good education, high school level or above. About 73% are unemployed at the time that we see them. So we're not actually seeing a lot of people that you would define as a functional meth user. And we have people whose lives are starting to fall a bit apart. So that's one of the things I think that you see pretty commonly with meth, is that people are able to sort of keep things together, only using meth in party zone or sex time, but then eventually things start to get a little shaky. Most of them are poor, so they live below our federal poverty level, and about 40% of them have problems with their housing, so they're homeless or have unstable housing. So we're seeing a really good population, and most of them who are insured are publicly insured, so they're paid for through state insurance rather than private insurance. So when you ask them if you've been using meth recently, we again are recruiting the right people for the program. The right folks are coming. About 91% overall said they used meth in the 3 months prior to their first visit with us. 94% of the HIV negative clients said they've used meth, and 89.5% of the positive clients said they used meth in the last 3 months. So these are pretty recent users that are coming to us, and so that is inherent with all the challenges that it comes with folks who are actively using meth who are seeking care. In terms of how frequently they're using meth, you'll see that overall, many say they use it less than weekly. The majority are using it 1 to 6 times per week, and there's some that use it 7+ times per week. So you can see it's about 57% are using it in that 1 to 6 time zone. And it's not that different between people living with HIV and HIV negative folks. In terms, one of the interesting things that we're finding is how people are using meth, which for us is really important. So first, some are using it orally. The majority are using it smoked. Some are snorting or inhaling it, but about 48% inject meth. And what we're finding is that our younger men of color are actually starting with injection, which is really concerning given that there's other opioids and other sort of risks with injection that are hard to manage. And so you'll see that injection is a significant part of what we see. We also have folks who use other drugs. The majority are using other stimulants like crack or cocaine. Some others are using prescription drugs, and heroin is really not very common, at least not that they're aware of, although it may be cut with the drugs. Now, what other drugs are they using? I bet just like here, GHB, number one. Like there's so much concurrent meth and GHB use. Ecstasy, Molly, ketamine, a little bit less common for these meth users, but G is everywhere, and I think I heard that G is everywhere here too. And then when we look at scaling their substance use disorders, we actually used a severity scale, and again, just to demonstrate that the right people are coming to this harm reduction focused program, almost all of them have a severe drug problem if you score them on a mental health score of severity. So we're seeing the right people. So our next plan is, we're really going to do a lot of work on assessing this program, so I'm not going to read this. What's really important to us is that we're learning that we're reaching the right people, but we want to demonstrate that a program that is a one-stop shop that focuses on harm reduction as well as abstinence could provide an option for methamphetamine users. And what I'm really, really hoping that we're going to be able to do is to demonstrate real-world evidence that if you give people medicines to replace methamphetamine, that you have some success. And so I think that that's something that's been missing, and I think is stigmatized in lots of communities talking about substance use and abuse. I think we need something that is a medication-assisted therapy for methamphetamine and cocaine abusers. Then ultimately, and just really quickly, since I think I am running out of time, I'm going to talk a little bit about the work that we're doing in our sexual health clinics. We have 8 clinics throughout New York City. Their focus is really on sexual health, STI screening, HIV testing, etc. What we did is we're starting to blend drug services deeper into the sexual health clinics. So included in there is that we're doing Narcan. We're giving opioid overdose prevention drugs out to people for free if they were using any drugs. And then also we have made our clinics syringe availability clinics, so you can come and get clean syringes if you're using syringes no matter what drug you're using. Additionally, for the last 10 years, we've been doing screening for substance abuse and mental health problems, and the effect really has been that we're getting more and more people into services. And so this is a part of what we're doing. And the best news is that they also refer to the recharge program. So we meet people who are coming to get tested for syphilis, and they get talked about methamphetamine and recharge. So I have more slides, but I'm not going to go any further because I want to make sure we have time for discussion. And so, Roy, I'll bring you back up, or?
Yeah.
Great.